Welcome back to the Changing Landscape of Hemophilia Management, presented by Albert Einstein College of Medicine of the Yeshiva University at OMed Live. Our next session is entitled Overcoming Barriers to Adherence in Hemophilia Treatment. My name's Susan Karp, and I'm the nurse coordinator of the Hemophilia program at the University of California at San Francisco. Joining me today is Sue Cutter, Assistant Director at the Penn Hemophilia and Thrombosis Center and the social worker at the Penn Comprehensive Hemophilia Center. Today's session is a live, interactive program that allows us to take questions in real time throughout this presentation. I encourage you to send us your questions anytime throughout by typing them in the box located at the lower left-hand side of your screen. I'll now begin our discussion and then turn it over to Sue later in the program. I would like to thank CSL Behring, Baxter Healthcare, and Grifols for their support of this important educational activity. Okay, my presentation is entitled Overcoming Barriers to Adherence in Hemophilia Treatment. So for years we have used the term compliance when we talk about asking patients to do what we recommend, because it suggests that compliance suggests that a person is more passively following the doctor's order rather than actively collaborating in the treatment process. As a result, we now use the term adherence because that requires that the person agrees to the recommendations for therapy, and it's defined as the extent to which the patient continues the agreed upon mode of treatment with limited supervision when faced with conflicting demands. So hemophilia treatment in the 21st century. Current treatments include the use of factor VIII and IX concentrates for patients with hemophilia to stop bleeding. There are approximately 150 hemophilia treatment centers federally funded throughout the United States, and we use a model of what we call comprehensive care with a multidisciplinary team of providers to address all the patient's biopsychosocial needs. We emphasize that patients should live as normal a life as possible, and in this day and age, for patients who do not have hepatitis C or HIV, life expectancy is comparable to the general population. Future therapies for patients with hemophilia include the longer-acting factor products, which Dr. Fogarty just spoke about, and gene therapy. So what are we really concerned about in hemophilia? Well, the greatest morbidity in hemophilia is bleeding into the joints. People with hemophilia bleed into their joints, often without trauma. Joint bleeding is extremely damaging to the joints. It leads to destruction of the cartilage, joint contractures, and often the need for extensive orthopedic surgery. And the prevention of joint damage is really a primary focus of hemophilia care today. So severity of hemophilia. About half of our patients have factor levels which are really undetectable, and they may have spontaneous bleeds, often without trauma. We also have patients who have moderate hemophilia, where their factor level is between 1 and 5%, and patients with mild hemophilia who often only bleed with trauma, surgery, or procedures. One of the modes of treatment that we practice at the hemophilia treatment centers is prophylactic factor therapy. And prophylactic factor therapy is when factor VIII or IX is given intravenously to a patient, generally every other day, sometimes 3 times a week, sometimes weekly, to prevent joint bleeding. And the aim of prophylaxis is to keep the patient's factor level above 1 to 2% so that in fact they no longer have severe hemophilia and will not have these spontaneous bleeds. And one of the pivotal studies was the Joint Outcomes Study, which was done and published by Marilyn Manco Johnson in 2007. And they had 2 groups of young children. One group of the children was on prophylaxis, every other day factor replacement therapy. The other group of children were on demand, which meant that they treated themselves when they had a joint bleed. And they found that the prophylaxis group reduced the incidence of joint bleeding in the young children with hemophilia and lowered the risk of joint damage. And as a result of this, MASAC, which is the Medical and Scientific Advisory Council of the National Hemophilia Foundation, and is composed of experts in hemophilia from around the country, made this treatment recommendation that prophylaxis be considered optimal therapy for individuals with severe hemophilia. It should be started early when the children are quite young, either prior to the onset of bleeding or sometimes after their first or second bleed, and that it may be beneficial to continue this therapy throughout the patient's lifetime. I will say that there are still a lot of patients who prefer to use on-demand treatment, and that the literature concerning adherence discusses adherence to prophylactic regimens, but the same concept may be applied to patients who we would like to adhere to prompt treatment of their joint bleeding. Well, do patients really adhere to our treatment recommendations? Well, several studies have found that as many as half of the patients really are not what we would call adherent to our treatment recommendations. And we'll talk about what are some of the barriers to that, to adherence. In particular, adolescents tend to not be as adherent. Young children are often adherent to therapy as their parents are really the ones who are practicing adherence, and the parents are caring for their children. Adolescents, as we know, often go into denial about some of their health issues. They tend to not want to do what they're told to do, and they have gotten really very tired of getting stuck for their prophylactic regimen every other day. And so many adolescents will actually stop their prophylactic regimens at home. And is that okay? Well, there's not a real consensus concerning the recommendation for continuing prophylaxis into adulthood. And it may be that as many as half of the patients could actually successfully stop their prophylactic therapy because they really have good joints and they've reduced their activity levels and so forth. But a good number do need to continue that once they stop, they find that they have an increase in their bleeding rate and they really need to continue on the prophylactic regimen. What about adults? Again, adults often have not been on prophylaxis as children, depending on their age. And we do encourage the adults to be on prophylaxis because it's been found that quite a large percentage of adults do have bleeding, do continue to have joint destruction, and it is important for them to be on prophylaxis. So what are some of the factors affecting adherence? What do we face as treatment providers? Well, lack of communication can be a problem. We all are very busy in our day-to-day life at work. We're rushed to see patients. We have limited clinic time and space, and we often don't have the time to really sit and talk to patients about why it's important for them to treat early, for them to be on prophylactic regimen, and to decrease their risk of joint bleeding.